Good morning and welcome to this HealthyU presentation by Colorectal Health. This morning we're going to be talking about the laboratory screening for colorectal cancer, a critical issue for all of our health. I am John Tomaszewski. I am Chief of Service for Pathology and Laboratory Medicine at Colorectal Health Laboratories. I'm also Chair of Pathology and Anatomical Sciences at the University at Buffalo. I am a practicing pathologist. I've been doing this for 40 plus years, and I'm very pleased to be speaking with you this morning on this topic. So the learning objectives for this session will be to explain why early detection of colorectal cancer is really key for the identification of those tumors at a curable stage. We want to catch them early. So I'd like you to understand at the end of this session why regular laboratory testing of stool samples, fecal samples, and then reflex follow-up of any positive to endoscopy are really important components in an effective screening program for colorectal cancer. So what are we talking about here in terms of the disease and the risk and the occurrence in the population? So this is these are statistics from 2020 from the American Cancer Society, and you can see that the total number of colorectal cancers is about 147,000 in 2020. And there were 53,000 deaths. That's across all ages. I'd like to point out for the seniors in the group, myself included, that the majority of those were actually in the 65 plus year range. And so this is a disease that can strike all ages. So you need to be aware of that, but it is also a disease that is more common in the advanced years. There's an increase of incidence of colorectal cancer in men over women. The same thing is true of the mortality. But this slide actually shows a hopeful statistic, and that is that if you look at the incidence of colorectal cancer, the rate per 100,000 population, it's been going down since about the year 2000 or mid-2000s. And so this is the time when screening for colorectal cancer by colonoscopy, that is a direct visualization of the inside of the colon, really took off. And so we imply from this these data that colonoscopy is an effective way of screening for colorectal cancer. Why do we want to screen for colorectal cancer? Well, it has to do with detecting the tumor at early stages. So we've learned in pathology over decades that there is a sequence of events in the development of colorectal cancer. They start out as these little tumors that we call adenomas, and then they turn into cancer, but they're small cancers at the beginning, stage 1 and stage 2. And then they start to invade the wall of the bowel and get to the regional lymph nodes, that is stage 3. And then when they're big and bad, they have a lot of tumor cells. They invade regional nodes, but they also spread to other places like your lung and liver and things like that. So we know that these tumors have to go through these stages, most of them, from adenoma to that stage 4. And if we can find them early, we can take them out and avoid the killing cancers. So the whole goal of screening for colorectal cancer is to avoid the stage 4 cancers. And these stage 4 cancers are the ones that kill people. This data from 2020, I believe, shows you that in the context of a colorectal cancer staging system, when you put a screening program in place, you capture more early stage cancers. So if you look at these two curves, they're sort of going parallel up to about 2007, 2008, when the colorectal cancer screening programs by colonoscopy went in place. And at that point, we start to see more cancers found at an early stage, and then we see the declines. So the conversation is really about identifying cancers early to avoid that big bad tumor that can go through the bowel and go to distant organs and kill you. So since we know this, why isn't everybody getting screened? Well, patients have issues with how the screening is performed, and there are barriers. So these are patient-reported barriers to colorectal cancer screening. One of the big things is the information isn't conveyed, that screening's important and recommended, so patients report that their providers don't recommend it, or that's one of the issues. A second issue is what we all worry about. What's going to happen? How's this procedure going to go? What's the outcome going to be? Is it going to be discomforting? Is it going to be painful? That's a worry. There's cost to this. So financial challenges, lack of insurance, the cost of the testing are all issues. Many people just have logistical challenges. Getting to their appointment at the right time is an issue. Some people aren't really understanding that this is a high priority thing, and they think it's I'll get to it when I get to it, and they lose their opportunity to avoid bad things happening. And then, as I mentioned above, patients would specifically report that they have a fear of discomfort with the procedure or the preparation for the colonoscopy, because the bowel has to be cleared before it can be inspected visually. So these are all things that are barriers for patients to getting to colonoscopy. Is there any way around that? Well, this is data from Kaiser Permanente. This is a big health system. It started in California, and they organized a screening program, which, if you look in that sort of number 2 there, put together colonoscopy, and that's that little black diagram there for a colonoscope, and laboratory testing. FIT testing. We'll talk about that in a second. They put that together in year 2006, and then they had a very aggressive screening program. They engaged patients in the screening. And you can see on the right-hand side the curves for up-to-date screening, which really took off around 2006 and sort of plateaued out around 2010 or 12. And also the cancer mortality rates going down at that same period, implying that this screening program in that population really mattered. It was finding these cancers and finding them early and avoiding death. So we think that screening programs such as this are valuable ways of improving the health of a population. In those studies, there were different types of tests that were done in that screening program. It wasn't just the colonoscopy. It was colonoscopy, another technique where they just look at the lower part of the colon, sigmoidoscopy, and then there were 2 stool-based testing. One was something called fecal immunochemistry testing, FIT testing, and the other was this guaiac-based fecal occult blood testing. and we're going to talk specifically about this. And in their screening program, in their success in this Northern California study, the investigators really identified upticks in colonoscopy and the fecal immunochemistry testing as being the drivers for keeping the screening up to date. So the important point is that you may need a couple of different methods of screening to get a lot of people to engage in their own health care. So we've been talking about screening tests. What are they? So in the green highlight here, I listed what we call visualization tests. That's where we actually look for one of those tumors. We look for the adenomas or the small cancers or the big cancers if it's late. But we actually look in the bowel. So one of the ways, the most common way of looking in the bowel is to do a colonoscopy. So it's a sort of a mini microscope, if you will, a 10x lens on top of a fiber optic imaging system that can look at the mucosa of the inside of the bowel. So you're looking at the bowel from the inside, and that's the most common. Other techniques that are out there are using CT, computed tomography colonoscopy, so it's an X-ray approach. Another would be we're only going to look at part of the bowel, the lower part of the bowel, flexible sigmoidoscopy. And then another would be we're going to actually do that sigmoidoscopy with some stool testing, fit testing, for example. So we're looking at the bowel. The other kind of screening test is what we're talking about this morning or focusing on, and that is stool testing for colorectal cancer. And this is in the amber highlight there. So there are several tests there. There is the high sensitivity guaiac fecal occult blood test. What a mouthful. We're going to we'll abbreviate that as GFOBT. There's the fecal immunochemistry tests. I can't even say it. And we'll call that FIT for short. It's easy to say. And then there is the multi-target, S means stool, DNA FIT test. So it's a combination of the fecal immunochemistry testing and this newer testing called DNA testing. And I have to mention here that one of the developments in molecular biology understanding is that not only does the tumor go from a little tumor to a big tumor, but along with that change in size, the tumor picks up genes or gene mutations that weren't in the little tumor. So a bigger tumor has different genetic mutations than a little tumor. So these are the kind of stool tests that we'll be talking about here. Now, there is this group called the U.S. Preventative Services Task Force for Colorectal Cancer Screening in asymptomatic patients. These are, you're feeling fine, everything's good, you're going to your doctor, and your doctor says you need to get screened. For people of average risk. Now, there are people who have high risk for colorectal cancer. You had a family member with colorectal cancer. You have a disease like inflammatory bowel disease. These can really increase your risk for colorectal cancer. We're not talking about those people. We're talking about everybody else out there of age 45 and over and that has no risk history associated with them.